Okay guys, we're going to get started where we left off with chapter 3. I gave you some terms in the chapter as well as table 3.1 that you needed to know. There wasn't much there. We started talking about managed care organizations, and we talked about gatekeepers and primary care providers. So we also practiced the competencies that you'll have next Wednesday. That will be for chapter 3, that'll be the pre-authorization that I told you to work on over the break, and then the referral that I told you to work on. And it will be pretty much exactly the same. And the competency, just a reminder, is 85% for each one is what you have to make. So we're going to pick up on page 47 with quality assurance, and I'm going to go with the book as well as the PowerPoint. So let's look on page 47, quality assurance, and talk about it because it does have a huge part and a huge impact in insurance. Quality insurance is activities that assess the quality of care in a healthcare setting. So you have government oversight, patient satisfaction surveys, that's a big one. Data from grievance procedures, reviews by independent organizations. And there's quality assurance for each different department, like the laboratory also has quality assurance that they have to do. But basically we are checking the P's and Q's and trying to make sure that we're giving the patient the best care that they're supposed to be having. Look at the let's look at the QISMC. The QISMC, which is the middle paragraph on 47, this is the quality improvement system for managed care. This ensures that managed care companies stay accountable of plans through objective, measurable standards. So they have to have certain standards like we do in with education. We have to have standards or objectives. So this quality assurance group or system for managed care does that. They have measurable outcomes basically in standards. Then look at HEDIS. Actually, yeah, let's talk about the HIDIS. This means what this organization does is measure. It looks at performance measures to evaluate the managed care. So it's kind of like it gives each place a report card of how they're doing, and that is a key term in your textbook. And it says the report card contains data regarding a managed care plan's quality, utilization, customer satisfaction, administrative effectiveness, financial stability, and cost control. So that's just quality assurance on the insurance side. And remember, quality assurance is really in each department, whether you're in a hospital or an outpatient facility. So going on to a word that you may hear commonly is utilization management or utilization review. And this is a system of controlling cost, healthcare cost, and the quality of care by evaluating the care provided. So it's very similar to quality assurance. And when they come in to check your medical records or to, I'm not sure what all they do now, but it's called a utilization review. Okay, and that kind of goes hand in hand with that report card. Look at that list at the bottom of page 47, the bulleted list. It says this is what they perform. They do the pre-admission certification, which is a review for medical necessity of inpatient care prior to the patient's admission. So this is like what an insurance company will do while you're waiting on the phone or waiting to hear that they're going to approve your patient's admission into the hospital. Pre-authorization, which we've talked about a little bit, and we've practiced doing one of those. This is a review that grants prior approval for reimbursement of a healthcare service. So like if they have MRI, CAT scan, upper GI, barium enema, whatever it is, they have to have pre-authorization. And don't forget, like I told you yesterday, you have to have a diagnosis. You have to have a diagnosis that also links to the procedure that they're going to cover. Okay, you also need to get the pre-authorization number, and the person's name, and like the date and time that you called. Any information that you can give is good, because you always want to have that backup. Concurrent review. This is a review for medical necessity of tests and procedures ordered during an inpatient hospitalization. So basically, if you're staying in the hospital and I need to do an MRI on you tomorrow or a colonoscopy on you tomorrow, then the insurance company will do this concurrent review. And then you have like a discharge planning or a discharging review. And this involves arranging appropriate healthcare services for the discharged patient, okay? And, if I send you to home health care, there better be a good diagnosis and a reason why I'm sending you to home health care. Otherwise, the insurance isn't going to pay for it. So that's why discharge is included in planning and managed care as well. Okay. Let's see. Let's look at a URO. A URO is used by some managed care plans for establishing a plan or a program. And this is usually in hospitals. Somebody can start the URO, or it could be, an office too. The TPA, make sure you know this, third-party administrator. It's just a big abbreviation, or a small abbreviation for third-party administrator. So these provide health benefits, claims administration, and other outsourced services for self-insured companies. So that's what TPA stands for, third-party administrator. All right, let's look on page 48 at case management. And again, this all goes hand in hand. Utilization review, case management, quality assurance, it all links together. But case management develops cost-effective patient care plans for difficult cases. And really now, even when they're not difficult, they may still have a case management on your specific hospital stay. But it was mainly started for difficult cases. So let's see. So let's say that you're having, let's say one doctor says that you need surgery, and when you do your pre-authorization for surgery, they say, no, I don't think they need surgery. We may do, we want a second opinion. And so this is when you have a case manager that specifically manages your patient information. And then with that said, look on page 49, it's second surgical opinions. Okay, this doctor is, like I just said, they're asked to assess the need for surgery. And it says in the PowerPoint, remember, if it's mandatory by carrier, you have to place a 32 modifier on an E&M code. And right now that sounds like another language to you. That's one of the things that I dislike about this book, is we haven't discussed coding yet. And so every once in a while they place those codes in here, so, and you don't really know what they're talking about. But anyway, that will make sense in a few weeks. The E&M service also should be a new patient visit, not a consultation. And that will again make more sense the more we go. But just remember that a second surgical opinion is usually required by a case manager that deals with your insurance. Let's go on to gag clauses. This is the gag clause prevents physicians or other providers from discussing treatment options with the patient, whether or not the plan will provide reimbursement. So that's what a gag clause is. It also says in your PowerPoint it's prohibited from managed care contracts, and it ensures that all medical advice is given whether or not treatment is covered. So before, a lot of these gag clauses and these rules came into play, they would, only get reimbursement if they didn't do surgery, or, et cetera, et cetera. The physician will get a little payout. And so, unfortunately, some insurances are still like that today, but this gag clause kind of helps cover you. It's for the patient. And basically it says that the physician has to cover every single option, whether it's reimbursed or not, with a patient. So that's what a gag clause is. Then we go to physician incentives, which kind of goes hand in hand with what I was just saying. So these are payments that are provided to physicians to encourage them to reduce or limit a specific service. Okay, so Medicare requires that plans contract with Medicare and Medicaid to disclose all physician incentive plans before a contract will be renewed. Okay, so if it's time for their Medicare and Medicaid to be renewed, they have to basically go through a utilization review to make sure that Medicare and Medicaid will be offered again. And then let's go to bottom of page 49, the managed care models. We've mentioned a couple of these, but you do need to know these. The first one is the EPO. This is the exclusive provider organization. So you have one provider, and it's the most restrictive model. And you may want to remember that for test purposes. The EPO, or the exclusive provider organization, is the most restrictive of the models. The member must receive all care within the network, okay, and it's usually a very small network. Any care that's received outside the network results in the patient paying full cost. Then we have the IDS, the Integrated Delivery System. This is an organization of affiliated providers, like certain physicians, certain hospitals all together. They offer joint healthcare services to subscribers. So right here you have a PHO, MSO, GP, WW, IPO, medical foundations. So, and you'll see a lot of physicians doing this kind of model, where they go to these certain physicians to be treated. Then we have the notorious HMO, the Health Maintenance Organization. This is definitely a big proponent of preventative services, but the HMO is going to provide comprehensive services to voluntarily enrolled members on a prepaid basis. Provides preventative care services and health risk assessments, ensures members have a primary care provider or a PCP, and it uses co-payments. Okay, so after the HMO was invented, a lot of these other insurance companies kind of did their models from the HMO model, except maybe not quite as restrictive. So the closed panel HMO is you have a group model and a staff model, and those are a little more restrictive. And then you have the open panel, which is the direct contract model, an individual practice, or a network model. See, all of those are a little bit different. Let me see. Let's look at table 3.2 on page 51. We're going to skip that example up there because we're going to mainly talk about that in the next chapter. Okay, so just kind of skip that right there. But let's look at table 3.2 on page 51. The closed panel models, you need to know about the group model and the staff model. Okay, I'm not necessarily going to make you know what it is. I just want you to know that two types of closed models are the group and the staff. Same thing with the open panel models. You have the direct contract, you have the individual practice association, and you have the network model. All three of those are part of the open panel HMO models. Alright, going on to page 52. We're going to talk about the POS, which is point of service. This is a somewhat popular plan to have. This offers freedom to use managed care panel or do a self-refer. So if it's an in-network service, then you have like your standard out-of-pocket expenses, like your copay or deductible. And if it's out of network, you have to do, your percentage up front usually. So your co-insurance, besides being billed at a later time for your co-insurance, you have to pay 20% of a certain fee up front. And usually the office will tell you what the fee is up front. And sometimes they will not do that, and then that's why you get a big bill a few weeks later. So that's what point of service is, and it's a pretty good model. Then we have the PPO. This is probably one of the more common ones that you have seen. This is a preferred provider organization, very similar. It's a network of providers, hospitals, etc., that have a contract with the insurance company. And it's a contract basically to provide health for patients, for the insurance members. So the use of non-PPO results in a higher out-of-pocket. So it doesn't mean you have to pay the full price, but you have to pay a higher out-of-pocket. Also, premiums, deductibles, and co-payments are also higher than an HMO does. But PPO, again, as long as you go in network, even with referral, you can do it. It's still a little better than HMO, in my opinion. The TOP, the triple option plan, and we also call this a cafeteria plan, because when you go through a cafeteria, you have choices of several things. This is what a TOP, or a triple option plan, is. So you may have a choice of HMO, a PPO, a POS, some other managed care organization, and you can kind of choose what you want, or you could choose more. Maybe one is your primary, one is your secondary. So, and a lot of people will do that. They'll choose like a POS as their primary, or a PPO as their primary, and then a POS as a secondary. So when they do go out in network, that secondary insurance picks up and pays a little bit more. So that's what a cafeteria plan is. Going on to consumer-directed healthcare plans. This is at the bottom of page 52. These have very similar to cafeteria plans. You have a lot of healthcare options. So this provides incentives to people, or to patients, to control the cost of health benefits and health care. So they'll do an incentive like percentage off your premiums, or a free physical, etc. And it offers full coverage for in-network preventative care, so it covers totally. And this is a very common model used. The plans offer the freedom to spend up to a designated amount, and then members assume responsibility for higher cost sharing after a designated amount is expended. So you may choose to spend like $50,000 a year. And of course, that's going to be a higher premium for you to pay out of your paycheck. But once you go over that $50,000 a year, you're going to have to pay maybe not the whole price, but a higher price. Because you've gone over your maximum. But the higher the number is, the higher the premiums are going to be. Let's look at top of page 53 and talk about some limits that are associated with managed care. We have a tax-exempt account. So we kind of talked about this during the last class. So this is used to pay for healthcare expenses and provides more flexibility than traditional managed care plans. Out-of-pocket payments for healthcare expenses, which are made after the tax-exempt account is expended and before the deductible for high deductible insurance has been met. High deductible insurance policy, which reimburses allowable healthcare expenses after the high deductible has been paid. So those are just some limitations associated with these particular plans. Let's look at table 3.3. I want you to skip that first one, but let's go to the flexible spending account, or the FSA. This is a very popular thing right here. This is basically what we discussed in class 2. You have a certain amount of money that you pay into it through your paycheck. They send you a card and you can use it for whatever medical expenses you need, whether it's a copay, medication, etc., they'll pay for it. But once you use your amount that year, you can't use it anymore. So that's what a FSA, or flexible spending account, is. The next thing I want you to know is the next to last one down, healthcare reimbursement account. We call these HRAs or HCRAs. These basically, again, are tax exempt, but you have to pay out of pocket, and then you get reimbursement. So it's kind of like a rebate, and that's why a lot of people don't like those, because you do have to come out of pocket at first. And then the HRA, to get a little more specific, is the last one that I wanted you to know. These are used for practices that have more than 50 employees. So if you have more than 50 employees or a certain number of employees, the better, the less out of pocket you have to do with these HRAs. So those are the three in Table 330 that I want you to know. All right. Let's look at the accreditation on page 53. A lot of you, I'm sure, have heard of the word accreditation, but this is a voluntary process that a healthcare facility or an organization participates in, and they have to demonstrate certain outcomes or certain objectives and their outcomes. They have to, and it's a law, so they have to meet them, or they get on probation, they could lose their accreditation. That's what accreditation is. And if you look, the term I want you to know is the NCQA, the National Committee for Quality Assurance. This is the committee that reviews accreditation plans and reviews your practices or your hospitals, once every 5 years, once every 10-year plan. So let's go on to bottom of page 53 and look at these bulleted points. Let's talk about how managed care affects a physician's practice. Number one, you have to have separate bookkeeping systems for each plan, okay? And this is to ensure, basically approve your finances. You know, how many patients you have for Blue Cross Blue Shield, how many you have for Evergreen, etc., etc. Two, a tracking system for pre-authorization of specialty care and documented requests for receipt of the specialist treatment. So you have to have basically like consultation reports. Those are required. So you, as the office employee, will need to keep that little tickler file and see who did you refer them to. A week or two after their referral and their visit there, then you should be getting a consultation. If not, you need to call and get it. So that's, again, where that tickler file comes in handy. The fourth one, up-to-date list for referrals to participating healthcare providers, hospitals, and test facilities. And then the last one, up-to-date list of special administrative procedures required by each managed care contract. And they are different. I'm sorry, it continues on page 54. List of patient co-payments and fees. Now, they'll keep a list, but now it's printed usually on the front of everyone's insurance card. And then when you verify it, which we'll talk about in the next chapter, you can see that what their copayment is at that time. Special patient interviews to ensure pre-authorization and to explain out-of-network requirements if the patient is referring themselves without a physician approval. Additional paperwork for specialists to complete in the filing of treatment and discharge plans. Some case managers employed by the MCO to monitor services, that utilization review. If a patient fails to keep a authorized appointment, you usually have to do more paperwork there. The attachment of pre-authorized documents to health insurance claims, and those have to be submitted. So you can see it requires a lot of paperwork with managed care that you have to keep track of. Let's see, and I think that is it. Yep, it is. So we will stop there. Before next week, you can, in the chapter review, you can do numbers 1, 2, and 5 in the multiple choice. You can do all of the matching, and then we'll go over that next week. Okay, and we'll try to again touch the top important points in this chapter if we have time.